Alright guys, so to start off topic number 1, anatomy, we're going to firstly look at the anatomy of the skeletal system. So this is looking at our bones, their structure and their function. In terms of the functions of the skeleton, overall it's got a few important functions. It supports the body, it provides that hard framework throughout our body. It protects internal organs, it creates movement, so we know that our muscles attach to our bones to produce movement, and it also supplies red blood cells to the body. So inside our bones, it's creating red blood cells and it's storing calcium, which is important for functions around the body. Now, it's easy to think of the skeleton just being like, bone structures that don't really change, but your bones are alive. They're always turning over and recreating themselves. So if you do a lot of heavy resistance training, let's say you're doing bodybuilding, your bones will respond to the stress of that and grow bigger and stronger. If you're bedbound, say you've had an injury and you're lying in bed and you can't move your leg for months on end, those bones are going to become weaker and more brittle. So bones always respond to the stress that we place upon them. So that's important to remember as well. Your bones are alive. They're responding to what you're doing. In terms of the skeleton, there's 206 bones overall in the skeleton, and we actually divide the skeleton into two parts. We divide it into the axial skeleton, which is shown in the picture in green, and the appendicular skeleton, which is shown in yellow. So in the axial skeleton, there's 80 bones, and the axial skeleton is the main axis of the body. So think about, you draw a line straight down the middle of your body. Those are the parts of the axial skeleton. It includes the skull, the vertebral column, and the thoracic cage. So just the things down the middle. And then the appendicular skeleton has 126 bones, and this is the appendages that attach to our axis. So our appendages being our arms and our legs, and the parts that attach those appendages to our central body. So the shoulder girdle is the name for like our scapula and our clavicle, which attaches our arm to the axis of our body, to our thoracic cage. So we've got the shoulder girdle, we've got the pelvic girdle, which again is our hip bones, which attach our leg to our central body, and then we've got the upper limbs and the lower limbs. Now, if we think about the functions of these two different skeletons, the axial skeleton's main function is protection. So if you think about the skull, what's the skull protecting? What's inside the skull? It's the brain. What's the vertebral column protecting? It's protecting our spinal cord. And then the thoracic cage, our ribs and our sternum, down the middle of our ribs, down the center of our chest, is protecting our lungs and our heart and our stomach and all the other stuff that sits up inside the top of that upper body. The appendicular skeleton, its function is movement. So your arms and your legs and the parts that attach the arms and the legs to the body, their main function is going to be allowing movement. Now, when we look at a skeleton like this, you guys can label as many bones as you know in the body, and I'm sure you'll know a few just from your previous studies, but it gets a lot harder when we look at a bone just on its own. So I want you to have a go at trying to name these bones as they come up without actually just naming them on the skeleton. This is a longish bone, so it's probably going to be in our arms or our legs somewhere, and this right here is the humerus of the upper arm. This one here, again, structure is quite long. It's got that big round head at the top, which fits in with our hip bone. This here is the femur. It's the bone of our upper leg. It's the longest bone in the body. Here we've got a funny triangle-shaped bone. It almost looks like a wing. This is our scapula. It's on our back. It's what attaches our arm to our body. So it's on the back of your torso. Here we've got another funny looking shaped bone. You're just seeing two pictures here because it's being shown from different angles, and these are our hip bones. And the correct name for the hip bone is the coxal bone, C-O-X-A-L. This is the coxal bone. And it is the pelvic girdle. It's what attaches the leg to the body. All right, important to know some of the parts of the vertebral column as well. So we know we've got these vertebrae running down the center of our back, protecting our spinal cord. If we look right at the top, the vertebral column starts right at the base of your skull. So we've got these vertebrae in our neck as well. The ones in our neck are called our cervical vertebrae, and there's 7 of the ones in our neck. Now, when we go to the upper back, these are called the thoracic vertebrae, and there's 12 of these thoracic vertebrae. So 7 cervical, 12 thoracic. In the lower back, we've got the lumbar vertebrae, which you can see they're getting bigger as they go down, as they're bearing more weight, because the bones lower in our body will have to carry more weight than the bones up in our neck. So they're getting bigger because they're responding to that stress of the weight that they're carrying around. So there's 5 lumbar vertebrae. And then we get down to the sacrum and the coccyx. And the sacrum and the coccyx are fused bones. So they actually appear as like one piece all together. But when you're born, they're individual. So when you're in the womb and you're a baby, these are all individual bones that over time become fused together. And there's 5 fused vertebrae that make up the sacrum. And there's 4 fused vertebrae that make up the coccyx, which is like a little tailbone right at the end. So 7 cervical, 12 thoracic, 5 lumbar, 5 in the sacrum, and 4 in the coccyx. Okay, now when we think about bones as well, we need to know how to classify bones. And bones are classified according to their shape, and their shape dictates the sort of need that they require. So for example, the femur, it's hollow and cylindrical. It's got a maximum strength with a minimum weight. So on the outside of the femur, we've got this dense, compact bone, but on the inside of the femur, it's mainly made up of spongy bone, which is sort of this like it's like spider webs almost. So it's very light on the inside. Your femurs are very light bones, but it's very strong bone as well. So let's go through a few different types of bone classification. And the first one, the most common one, is long bones. Now, long bones are like a rectangle. They're longer than they are wide. They all appear like a rectangle. Long doesn't necessarily refer to the shape. It doesn't necessarily refer to the size of them. It refers to the shape. So just remember, any sort of rectangle looking bone is a long bone. So it doesn't matter the size. You know, the femur is a long bone, but the little bones within our fingers are also long bones as well. So they're all that sort of longish rectangle shape. They often have a shaft with 2 bulbous ends, and you can see we've got the radius and the ulna in this picture as well. The radius being the one on the left and the ulna being the one on the right, and you can see they've got this long shaft, and then at each end they sort of become a little bit bigger. Now, they're primarily made of compact bone. So compact bone is the sort of hard, dense type of bone, and they have that small amount of spongy bone, which is the spiderweb system in the middle. And the examples are all of the limb bones. All of the bones in your limbs are long bones, except for your carpals, your tarsals, and your patella, and we'll see what they are soon. All right, short bones. Short bones are shaped like a cube, and they're made mostly of spongy bone, that spiderweb substance, with the compact bone surface layer. So there's compact bone on the outside, but on the inside of these, they're spongy like a little spiderweb in there. The examples are the carpals and the tarsals. They're the only examples you'll need to know of short bones. So right at the start of your hand, almost in your wrist, we've got our carpal bones. And then right at the back of your foot, like your heel bone, is a type of short bone. That's your tarsals. Okay, we've got flat bones as well. Flat bones are thin and slightly curved. They've got a large surface area because a lot of muscles attach to them, or because they're protecting something. For example, the skull is a flat bone protecting the brain, so it's covering the entire surface of the brain. It's made up of 2 parallel compact surfaces, which in the middle we have the layer of the spongy bone. So it's sort of like a sandwich with compact on the outside and spongy on the inside. The examples are the scapula, which we saw in the previous picture on the back of your shoulder, the clavicle, which is that S-shaped bone pictured there, the sternum, which is the bone which runs down the center of our chest at the very top, and the ribs as well are flat bones. All right, and then irregular bones. So irregular bones are always funny looking bones. They're a complex shape. They're made of mostly spongy bone with a thin layer of compact bone on the outside. And our examples are our vertebrae in the vertebral column, and you can see here two vertebrae pictured, and also the coxal bone or the pelvic girdle pictured as well is a type of irregular bone. And then finally, we have another type of bone called a sesamoid bone. And a sesamoid bone is a very special type of bone because it's a bone found within a tendon. And the only example of this is the patella. And you can see the patella, it's a little sesame seed shaped bone, and it's within that quadriceps tendon. So where the quadriceps come down and attach into your tibia, we actually have the patella lying within that tendon. So the patella is going to move with your quadriceps. It's contained within that tendon. It's not just floating there in your knee, it's sort of inside the tendon of the quadriceps. Okay, so just to go over it again, we've got long bones, which are the bones of our limbs mainly. We've got irregular bones, which are our funny looking vertebrae and our coxal bone. We've got flat bones, which are our sternum, our clavicle, our ribs, and our skull. And then we've got the short bones only found in our carpals and our tarsals. And the talus is just one of the tarsal bones. Okay, now the structure of a long bone. So if we're looking specifically at long bones, they have a few important structures that we need to know. They've got the epiphysis at both ends. That's that bulbous end, which I mentioned, sort of sticks out on the ends of long bones. And then the shaft is called the diaphysis. So we've got two epiphysis and one diaphysis. If we're going to be more specific, we can call the epiphysis at the top the proximal end, and the epiphysis at the bottom the distal end. And we'll talk about these directional terms soon, but proximal just means closer to the site of attachment of the arm, so it's further up the arm, and distal means further down the arm, and this can be used in reference to the legs as well. So proximal is further to the top of the leg, distal is further to the bottom of the leg. Now, if we look at the diaphysis, the shaft, again, there's a few important structures. Firstly, the periosteum. So if we break that word down, peri means around and osteum means bone. So the periosteum is around the bone. It's this connective tissue sheath that sort of surrounds the bone and contains the blood vessels and nerves, which supply the bone as well. And it's the anchor for all of our muscle tendons and all of our ligaments that attach to the bone as well. So periosteum is the surrounding layer of the bone. We've got compact bone in the diaphysis. So I said this is the thick, dense part of the bone, and you can see in this picture there the compact bone, which is full of osteocytes, which is the bone cells. And we've got spongy bone, which again is that spider web construction of the spongy bone, which allows blood vessels to run through it, and it mostly forms the inner layer of bones. And importantly, it houses the bone marrow. So the bone marrow within the bones lives here, and we'll talk about the bone marrow next. Now, the specific name for where the bone marrow is called the medullary cavity. So within this medullary cavity, we've got spongy bone, and we also have bone marrow. So in infants and young children, we have red bone marrow located in this medullary cavity. And the red bone marrow produces red blood cells, which we know are important for carrying our oxygen around in the blood. So our bones are actually creating the red blood cells, which will go into our blood and help us, use oxygen. In adults, it actually changes and it turns into yellow bone marrow, which carries fat. So yellow bone marrow is fat, red bone marrow produces red blood cells. Now, in adults, the red bone marrow is mostly found in the spongy bone of flat or irregular bones. So this right here, we're looking at a long bone. But if we were looking at a flat bone like the scapula or an irregular bone like the vertebrae, that's where in adults we're producing our red blood cells. It's not necessarily coming from the long bones. But what's interesting and what the body does is when someone is anemic, so they don't have enough red blood cells, the body converts yellow bone marrow to red bone marrow to increase the red blood cell production. So our body can actually change this around. If we need more red blood cells, it'll recognize that we need more, and it will start to convert the yellow bone marrow into red bone marrow to produce those red blood cells. Okay, we've got a few important features in the epiphysis as well. So at the end of long bones, we have articular cartilage. And articular cartilage is a type of hyaline cartilage. Just remember that term for later on. But articular cartilage covers the ends of all long bones because we know that these bones are going to be connecting to another bone, and the cartilage between them helps provides a smooth, low friction surface for those joints to move, or those bones to move on one another. So the articular cartilage is very important for allowing for movement and low friction movement between two different bones. We also have the epiphyseal line, which appears as a thin horizontal line, and it's visible on when you get an x-ray done. You'll see this thick sort of line between the epiphysis and the diaphysis. So the epiphyseal line, it represents the remnant of the epiphyseal plate, and the epiphyseal plate is called the growth plate, which is where bone growth occurs during children and adolescents. So in children and adolescents, they don't have a line, they actually have the growth plate, which is what is growing the bone. So bone growth occurs at the growth plate. And once our bones finish growing at the end of puberty, it sort of appears as this epiphyseal line. And it's got no real function in adult bones. It's just a sort of structural feature which tells us that the bone has completed growth. Okay, so to just go over those key points again, we've got the diaphysis, which is the shaft. It contains the periosteum, which is the surrounding layer, the compact bone, the spongy bone down the middle, and the medullary cavity, which carries either red bone marrow in children or yellow bone marrow in adults. We've got the epiphysis, which is the ends. We've got a proximal and distal epiphysis, which has got the articular cartilage, so that when it connects or articulates with another bone, we've got a smooth, low friction surface for movement to occur, and it also has the epiphyseal line. All right, so moving on, we're going to have a look at some directional terminology. So we need to understand these different terms, and it's like the language of anatomy, so it helps us to identify areas within the body. So they often appear in different pairs. So firstly, we have superior and inferior. Now, superior means above and inferior means below. So if I say the head is superior to the legs, that's correct. If I say the hand is inferior to the shoulder, that would be correct as well. So I'm describing the location by using above and below instead of saying superior and inferior instead. Superior, think of like your boss is your superior, they're higher than you, and your inferior is like someone who's below you. Okay, anterior and posterior. These mean closer to the front or closer to the back. So anterior means closer to the front surface of the body. Posterior means closer to the back surface of the body. So I could say the sternum is anterior to the vertebrae. Or I could say that my heart is posterior to my sternum. So it means forwards or backwards in terms of the direction that we're talking about. Okay, medial and lateral are referring to the midline of the body. So medial means I'm closer to the midline, and lateral means I'm further away from the midline, or I'm towards the outside, like I'm moving towards the outside edges of the body. So I could say that my ears are lateral to my nose, or that my belly button is medial to my hands. Superficial and deep refer to closer to the body surface or further from the body surface. So superficial is like more external and deep is more internal. So I could say that my hair is superficial to my skin. So it's more external to the body. Or I could say that my heart is more deep to my sternum. So it's further inside or more internal. Okay, and then finally, proximal and distal. These two are the ones that people tend to have the most trouble with. Proximal and distal only refer to the limbs. So you can only use these terms when we're talking about the arms or the legs. Proximal means closer to the point of attachment, and distal means further from the point of attachment. So distal is always down the arm, and proximal is always up the arm. So I could say that my humerus is proximal to my radius, or I could say that my my phalanges in my fingers are distal to my shoulder. So they're further down the arm. You can also use this in reference to the legs as well. Okay, the anatomical position is also important for us to understand. Makes it really easy when we use these directional terms. If we think about the anatomical position, first of all, it's the position that we always refer back to. If you're ever confused in an exam, go into the anatomical position and then use your directional terminology to figure out what they're talking about. So the anatomical position is with the body erect. So you're standing up, your feet are just slightly apart, your palms are facing forwards and your thumbs are out. This is always the reference point when we're talking about anatomy. And you'll see if you go to the physio, sometimes they'll have a paper with this picture, a picture like this printed out where they'll locate the sort of location of your injury or your problem area. They'll always use a picture like this to determine that. All right, we're going to talk about connective tissue now. So connective tissue, it supports and connects different tissues and organs in the body. Its functions include providing some structural support, cushioning organs, transporting substances, and the examples that we'll talk about today are cartilage, ligaments, and tendons. But it's also important to note that connective tissue examples might also be bone is a connective tissue, adipose tissue, so fat is also a connective tissue, and blood is a type of connective tissue as well. But today we're looking at these three: cartilage, ligaments, and tendons. So let's talk about cartilage first of all. So we've got cartilage in a few different areas of the body, and important to note with cartilage is it's avascular, and what that means is that there's a very low blood supply, so they don't have many capillaries, much blood, much nutrients going to cartilage, which means it gets low oxygen as well, and means that it's got a limited healing capacity. So when you injure cartilage, you can have a tear in a cartilage or wearing down of the cartilage of your knee, like the articular cartilage that's on the ends of the long bones of the knee. If that wears down after a while, it's really not good at healing itself. And there's three types of cartilage that we need to know. Firstly, there's hyaline cartilage, and its main function, hyaline cartilage, is to reduce friction. And you can see in the picture that the location of hyaline cartilage is all in blue there. So we have hyaline cartilage in the nose, at the end of long bones, and remember that's called articular cartilage, the cartilage at the end of long bones, but it's formed out of a type of hyaline cartilage. And we have also the cartilage between our ribs and our sternum, so that costal cartilage is a type of hyaline cartilage. And remember, the ribs don't go directly into the sternum. If it was just bone to bone, they wouldn't be able to expand like they do when we take a deep breath. So there's got to be some cartilage joining the ribs to the sternum to allow for that expansion of the rib cage during breathing. Now we have fibrocartilage as well. The main function of fibrocartilage is shock absorption, and it's pictured there in red. So we have fibrocartilage in the knee, at the meniscus of the knee. So the meniscus in the knee is just a little bit of cartilage that's there to help support and provide some shock absorption to the knee joint. We've got the pubic symphysis, which is the joining part of those two coxal bones at the front. So, if you press really low down on your stomach, almost in your pubic area, and you press down, you can feel where those bones connect at the front. You're feeling your pubic symphysis, which is made out of fibrocartilage, and also in the vertebral column. So the intervertebral discs are what lie between each of the individual vertebrae, and they're made of fibrocartilage, which helps with the shock absorption through the vertebral column. And then finally, we've got elastic cartilage. We've only got one example of elastic cartilage that we need to know, which is in the ear. And if you play around with your ear and you move it around, it always springs back into shape. So elastic cartilage, it's in the name, it springs back into shape. All right, ligaments. So we know that a ligament joins bone to bone, and they have their main function is stabilizing joints. So around all of our joints, mostly all of our joints, we've got ligaments, and their mechanism or the way that they stabilize joints is to resist tension. So ligaments work when they get pulled apart. They tighten up and they don't allow that joint to move any further. So For example, if you sprain your ankle, that's an injury to the ligament of your ankle. So that ligament's been stretched more than it would like to be, and it's gotten a little tear in it. So they're a flexible structure and they have a great resistance to tension. They work when they get pulled apart. The main ligaments that you guys probably all know about is the ACL, which is inside the knee, the anterior cruciate ligament. And there's also a posterior cruciate ligament called the PCL. We've also got ligaments on the outside of the knee, on the sides there, you can see in this picture. But they work when they get pulled tight. When they get pulled apart, the ligament pulls tight to restrict that movement and to stabilize the joint. You can see around the hip as well. So this is the femur joining into the coxal bone. We've got heaps of ligaments that surround that joint to help to stabilize that joint. All right, and then tendons join muscle to bone, and their function is to enable movement. They do this by transmitting the force generated by muscles onto the bones. So each muscle has got at least 2 tendons. Some of them have more, but 1 tendon at the origin of the muscle and 1 tendon at the insertion of the muscle. So the muscle goes through the tendon to connect to the bone. They store elastic energy as well, so that's important for during movement. They aid in efficiency and reducing muscular effort by almost being like elastic-like structures, so our muscles don't have to work as hard. All right, and then finally, let's talk about joints. So joints and articulations. Now, an articulation is the anatomical name given to the point of contact between 2 bones, and it's commonly referred to as joint. So joints, articulations can be used intertwinedly. An articulation is a little bit more correct, but we all say joints. They are very versatile and they allow for a wide range of movements. So depending on the joint that we're talking about, there can be a lot of movement going on at that joint. And we've also got joints where not much movement or no movement takes place. So the more movable a joint is, the less stable it is. And you can think about that in reference to the shoulder. The shoulder joint is probably the most movable joint. It can move a lot. There's a lot of range in your shoulder. You can bring it all the way up to your head, all the way back down. You can bring up your arm in front of you, back behind you quite far as well. And that is good because it gives us range, but it's also not good because it makes it very unstable. So there's a lot of joint dislocations at the shoulder which occur as well. So just keep in mind that the more a joint can move, the less stable it's going to be, and the more likely there can be some sort of dislocation or injury to that joint as well. So in terms of classifying a joint, which is the next thing we need to know, is to classify a joint, you need 3 pieces of information. We need to know the class or the structural class of the joint, the type of joint, and the mobility of the joint. So it's actually easier if we start with the mobility. So there's 3 different types of mobility, 3 different types of movement or how movable a joint is. So a synarthrotic joint means there's no movement at all between those 2 bones. It's still. Just remember synarthrotic, S for still. Amphiarthrotic, a little bit of give. So there's a little bit of movement between these 2 bones at this joint, but there's not much movement at all. It's just a little bit of give. Diarthrotic joints are freely movable. So our diarthrotic joints are what allow us to move day to day. They're the most common in the body. But just remember, diarthrotic is freely movable, synarthrotic is still, and amphiarthrotic is a little bit of give. Now, in terms of structural class, again, we've got 3 different classes of joints. So they're determined by the type of connective tissue that binds the bones together and whether or not there's a joint cavity present. So the first class is a fibrous joint. So this is 2 bones that are joined together by just fibers, and there's no joint cavity. So it's just these thick fibers that join together 2 bones. A cartilaginous joint is 2 bones joined together by just cartilage. There's also no joint cavity, so it's just cartilage holding these 2 bones together. And then lastly, a synovial joint, which are the main joints that we think about day to day. They're, our shoulder, our elbow, our hip, our knee are all synovial joints. They have fibers, they have cartilage, and they have a joint cavity. So fibrous joints is just fibers, cartilaginous joints is just cartilage, synovial joints is fibers, cartilage, and a whole joint cavity. And we're going to go over what that joint cavity looks like in just a moment. But firstly, let's talk through the different types of fibrous and cartilaginous joints. So if we look closer at our fibrous joints, there's not many examples of these in the body, so you only need to remember 3 different types, and they've only got 1 example each. These are our bones connected by just fibers, and the length of the fibers that join the 2 bones together determines the amount of movement. So firstly, we've got a suture joint. This is our first type of fibrous joint. So a suture joint is 2 bones joined together by short fibers, and they are synarthrotic. So the only example is the bones of the skull. So we know that our skull isn't just one whole bone. It's actually multiple sections of bone that are sort of joined together. And if you look at a picture of a skull, it's always got these squiggly lines on it, and those are at the suture joints that connect to them. Now there's no movement at all going on between the bones of your skull, and that's why the mobility is synarthrotic. It's still. Our second type of fibrous joint is a syndesmosis joint, and this is 2 bones joined together by long fibers. There's only 1 example right at the lower leg. It's the distal tibiofibular joint. So right at the bottom of the leg where the tibia meets the fibula, we have this syndesmosis joint, and you can see there's long fibers connecting the tibia and the fibula there, and the mobility is ampiarthrotic. So it's got a little bit of give. There can be a little bit of movement here, but if I asked you now to all move your syndesmosis joint, you're not able to do so. It's just when there's enough force and pressure, those bones can separate a little bit to allow for that, but it's not a movable joint. And then lastly, there's the gumphosis joint, and there's only 1 example of this as well. It's where your tooth goes into your gum. So just remember gumphosis, it's the tooth going into the gum. It's like a peg in socket joint, and the mobility is synarthrotic, it's still. So there's no movement going on between the tooth and the gum if your teeth are healthy, making this a synarthrotic joint. So again, there's only 3 examples. Well, there's only 1 example of each of the types, I should say. So suture is our skull, syndesmosis is the distal tibiofibular joint, and gumphosis is the tooth in the gum. Okay, for cartilaginous joints, remember these are bones joined together by just cartilage, and the type of cartilage helps us determine the type of joint. So for a synchondrosis joint, these are 2 bones joined together by hyaline cartilage. An example of this is the first rib to the sternum. So that first attachment of the first rib to the sternum is a synchondrosis joint. And then also at the growth plate of that epiphyseal line that we saw about earlier, this is actually a cartilaginous joint. And if you think about the growth plate or the epiphyseal line, you can't move the top of a bone off of the shaft, right? So it makes sense that the mobility is synarthrotic. And these are the only 2 examples in the body of synchondrosis joints. The other type of cartilaginous joint is a symphysis joint, and these are 2 bones joined together by fibrocartilage. So this is at the intervertebral discs. So remember, fibrocartilage is in between our vertebrae, and it creates what we call the intervertebral joint, where the intervertebral discs lie. And the second example of this is at the pubic symphysis. Remember, that's on another area that we get fibrocartilage in between those 2 coxal bones at the front. The mobility of these joints is amphiarthrotic, so there's a little bit of give. So we can move the vertebral column when we bend forwards and backwards. There's a little bit of give there between the bones. And then also the pubic symphysis, think about like a lady when she has to give birth. We're going to want that pubic symphysis to be able to move a little bit to allow for the baby to come through the pelvic girdle. So amphiarthrotic. Okay, and then our third class is synovial joints. So there's a lot more going on at synovial joints. Firstly, they include fibers, they include cartilage, and they have a joint cavity. So we need to talk about some of the features of this joint cavity as well. And the structure of the bones determines the amount of movement between these types of joints. Now, all synovial joints are diarthrotic, so they're all freely movable. And there's many different types of synovial joints. There's plane joints, hinge joints, pivot joints, saddle joints, condyloid, and then ball and socket, which is the one that you've probably all heard of. So in terms of the features of the synovial joint, firstly, the articular cartilage we can see is that hyaline cartilage on the ends of the long bones. We've got the synovial membrane, which secretes synovial fluid. So synovial fluid lies within the joint cavity and helps to reduce friction during movement. It also provides nutrients and oxygen to the articular cartilage and removes the waste products like other nutrients that we don't need and carbon dioxide. So in a joint, the synovial fluid kind of acts like blood would. It delivers the oxygen, it gets rid of the carbon dioxide. We also need to know we've spoken about articular cartilage, we've spoken about the synovial membrane, which secretes synovial fluid. We've spoken about the synovial fluid that lies within the joint cavity. Also important to know that at some synovial joints we can have a meniscus. So at the knee there's a meniscus, and it acts as a shock absorber and stabilizes the knee joint and helps to distribute the weight evenly across the joint and reduces the risk of injury. So the meniscus is a very important feature of the synovial joint. We can also have something called a bursa at a synovial joint, which is a small fluid-filled sort of sac near joints, which helps to reduce friction between, the tendons and the ligaments and muscles that surround the joint. We have these little fluid-filled sac called bursa, and they facilitate smooth movement. So those are the important features that I want you to know on synovial joints. Let's talk about these 6 types of synovial joints now. So firstly, plane joints. Plane joints are flat or slightly curved surfaces, and they allow for gliding movements in any direction. There's so many plane joints in the body. It's the most common joint in the body, but for you guys, I want you to know that in between all the carpals and in between all the tarsals, these are all plane joints. So where those carpals touch each other on every surface where they meet, we have a plane joint. A hinge joint is a U and a cylinder shape. It acts exactly like a hinge and allows for flexion and extension. So the examples include our elbow. That's our most common hinge joint. It just flexes and extends like a little hinge. Our ankle is also a hinge joint. And then in between the phalanges, so in between our fingers and our toes, we have hinge joints as well. So if you play around with your fingers, you feel that they can only flex and extend at those top 2 knuckles I'm talking about. So in between the phalanges. We've got pivot joints, which often includes a round sort of bone area enclosed by a ring or ligaments of some sort, and they allow for rotation. And we've got pivot joints at the top of our neck, which allows us to shake our head no. And then we've also got in between the radius and ulna a pivot joint, which allows for the action called pronation and supination. And we'll talk about that once we get to our movement terms. But pronation and supination is allowed by the pivot joint in between the radius and the ulna. Okay, we've got saddle joints as well, which have a convex and a concave area. They look exactly like a saddle. And the example I want you guys to know is the base of the thumb. So where the thumb meets your wrist, we have a saddle joint there. And that allows for flexion, extension, abduction, adduction, and opposition. So opposition is how humans became the one of the superior races, because we can oppose our thumbs and use that to build tools and so on. So base of the thumb is the really only example I want you to know for the saddle joint. And we're going to talk about what these movement terms look like and mean in class. Okay, a condyloid joint is an oval within another oval. So they do flexion, extension, abduction, and adduction. Now, if you think about an oval within an oval, it can flex, extend, it can abduct, adduct, which is mean move out to the sides, but it can't rotate. And that's a key feature of condyloid joints. An oval within an oval cannot rotate like a circle within a circle can. Examples are the knee. So the knee is actually a condyloid joint. It's a special type of condyloid joint. The wrist is a condyloid joint, so you can flex and extend your wrist. You can abduct and adduct it, but you can't twist it around. The base of the fingers, where the fingers meet the palm, is a condyloid joint. So the very first knuckle at the base is a condyloid joint. You can sort of turn it around in a circle. You can flex, extend it, abduct and adduct it, but you can't flip it around. So if you're looking at the back of your hand and you've just got one finger pointed up, you can't turn it around so I can see the other side of that finger without moving your wrist and so on. And then we've also got the base of the toes as well. So the first knuckle between the toe and the rest of the foot. And then finally, we've got our ball and socket joints. So our ball and socket joints, just like condyloid joints, but instead of an oval, it's a circle, which allows for rotation. And you can see there, we've got the same movements: flexion, extension, abduction and adduction, and medial and lateral rotation. So it can turn around in itself in a circle. Examples are our shoulder and our hip. Those are our two big ball and socket joints, the shoulder and the hip. All right, so a little bit of a recap on these. We've got our fibrous class, which has suture for short fibers, which is our skull, syndesmosis, the long fibers, which is the distal tibiofibular joint, and the gymphosis, the peg and socket, the tooth going into the gum. We've got our cartilaginous. We've got two different types: synchondrosis, joined by hyaline cartilage, and symphysis, joined by fibrocartilage. Can you remember the examples of these? For synchondrosis, it was the first rib to the sternum, and then the epiphyseal line or the epiphyseal plate. And for symphysis, it was the intervertebral discs and the pubic symphysis. And then we have our 6 types of synovial joints, which were all diarthrotic, shown here: the plane in between our carpals and our tarsals, the hinge at the elbow and the ankle and in between the fingers, the pivot at the top of the neck and in between the radius and the ulna, the condyloid at the base of our fingers and at the knee, the saddle, which is at the base of the thumb, and then the ball and socket, which is at the hip and at the shoulder.